welcome everyone. Good afternoon. I'm Paolo Michelutti. I'm a project manager at Agenas, the National Agency for the Regional Health Services in Italy, and we are the coordinator of the OASIS project. From my side, just a few words about this project for the ones who doesn't know yet the project. So the OASIS project is a project on medical deserts and specifically on promoting evidence-based reforms on medical deserts. The OASIS project aims, well, first of all, to identify and analyze quantitative methods for the medical desertification, meaning to find what could be the right indicators, the right data to measure medical desertification, and also to test some of these methodologies in the involved countries. We have 7 countries involved in this project that are Finland, France, Italy, Romania, Moldova, Hungary, and Cyprus. In parallel, we are also working thanks to the literature review, to identify what are the main determinants for the medical desertification, and also the possible solutions. The next steps will be in the 7 countries, in local sites, to have pilot studies in which we will test some of the indicators, and we will analyze at a local level determinants and possible solutions for the medical desertification, including also a discussion with the local stakeholders. So basically, this is the structure of our project. And today in this webinar, we are going to present you some of the interim results of the literature review. So Mona from THL Finland will present you the interim results of the main determinants and the solution to mitigate medical desertification. And then we will have 2 case studies from 2 of the 7 out of the 7 countries involved, one from Italy, one from France, on policies that have been implemented to mitigate the medical desertification. Okay, so as already Marta explained you, and I really also warmly invite you to, of course, listen to the presentation and then use the chat box and Q&A box to ask questions to the panelists, as we will have at the end of the 3 presentations specific questions sessions for the Q&A. Okay, so I'm going to mute myself and I give the floor now to Mona from THL to present the results and first evidences of the literature review. Please, Mona, the floor is yours.
Yeah, thank you, Paula. We'll share my screen. So I suppose you can see my presentation.
Right, yes, we see it, great.
Yeah, thank you. So I'm Mona Huhtakangas, researcher from Finnish Institute for Health and Welfare, and in our work package 5, we have conducted a literature review about the possible solutions to mitigate medical deserts. So some background for this: medical desert is defined as an area where people or patients have difficulties in accessing care due to long waiting times or long distance to care, or they may not afford services due to high service costs, or the provided services may not meet care, may not be adequate in relation to patients' needs. And often medical deserts are studied. So the lack of health professionals or professionals are distributed unequally within country. And what we aimed at to identify in our literature review was the determinants of medical desertification, focusing on the organizational factors and what would be the effective ways to mitigate medical desertification. And in here also focusing on organizational measures. So why our focus is on these organizational factors, because often policy measures to mitigate medical desertification are related to aspects like increasing education positions for healthcare professionals, but we were interested in how can we retain staff in organization and how can we avoid them leaving the organization. And often focus in studying medical desertification is in remote healthcare settings, but challenges in recruiting and keeping this both in remote and urban areas. And these organizational factors are the ones which can be affected by organizations themselves, such as how the workload is distributed between existing healthcare staff. And methods used were scoping review, and the main inclusion criteria for studies to be included in our review were focusing on organizational factors, primary healthcare setting, and first contact care, as primary care setting is often the first point of care for patients. So the focus is in there instead of specialized healthcare. And 5 databases were used to identify studies, and we included a total of 77 studies to be included. And shortly about the determinants of medical desertification, these are often related to shortage of professionals. There may be a lack of professional support or lack of support for professional development, like the maybe lack of professional support from colleagues, or then may not be mentoring opportunities available, or maybe educational needs are not met, like in remote areas, the professional education may not be provided in the same kind of way as in bigger cities. And the health professionals may have feelings of not being able to provide adequate care for patients. And especially in remote areas, there may be wide competence requirements for health professionals. If a patient with mental health issues comes to care and there may be lack of mental health professionals, then everyday physicians have to take care also of mental health issues, even though they do not have proper education in relation to patients' needs. And how work is organized is also one of the factors, like lack of professionals often increases workload for existing staff. And also the work may be quite unpredictable when there is a shortage of professionals. It's hard to take care of all the patients. And then to the ways to mitigate desertification, focusing on these organizational measures, how can we support professionals, possibilities for education, for example, in remote healthcare, remote education may be one of the solutions to digital health, digital education solutions. And adequate remuneration, not only payment, but also recognizing one's work and what kind of patient care they are providing, and emphasizing the feeling of importance of work and how work can be done in one's own way. And about the leadership, for example, if the workload is high, are there some legal to promote work as a way healthcare professionals do not have to carry on too much workload, and supporting one's autonomy, for example, work flexibility, how it can be promoted. And other main theme we identified about organizational measures was changing the way care is delivered. On the right side, there is task shifting, which means distributing responsibilities, for example, from physicians to nurses, such as vaccinations during COVID, or nurses can take care of patients with chronic health conditions. Task shifting also increases nurses' role, increases their autonomy, and possibly it can also increase the attractiveness of nursing job. And then extending opening hours and walk-in care are also possibilities for improving access to care for patients. And here on the left side are e-health, digital health, and multi-professional care, about which Guillaume and Lorenzo are providing examples afterwards. E-health provides for patients flexible access to care, and many health conditions can be solved remotely. Or maybe if in remote healthcare settings there is lack of professional, they can consult other professionals. And through multi-professional care, it not only provides professional support for healthcare professionals, but for patients. For example, patients with complex care needs, they can benefit from multi-professional care. And multi-professionalism also improves care coordination. And I think we can now move on to e-health example from Lorenzo. Thank you for my part.
Thanks a lot, Mona, for this overview on the evidence and results of your first literature review. And yes, as you well underlined, e-health is one of the possible solutions to mitigate or to overcome medical desertification. And we are pleased to welcome Lorenzo from the autonomous province of Trento in the northeast part of Italy, in which they are implementing actually an e-health solution, or different tools of e-health solutions. And so please, Lorenzo, explain us what you are doing in your province.
Thank you, Paolo, and let me thank also all the organizers of this conference for the invitation, also on behalf of the colleagues here in the province of Trento. I will share here, as you anticipated, a case of a strategy to overcome the medical desert by promoting digital health. And this is the case of our province. The reasons why we try to promote digitalization in our provinces has been already summarized more or less by the presentation before. We are witnessing what is called a perfect storm in public health that is putting at risk the sustainability of the system, in the sense that we do have an increased costs in terms of healthcare service delivery. We also have an increased number of patients, particularly diagnosed with chronic disease, but we also have a shortage of healthcare professionals that are putting our system at risk. And this is even more true, as it has been already underlined, in rural areas. And in our case, the province of Trento is actually a very specific area from this perspective. We are close to the Alps, and a significant amount of people living in our province is actually living in rural areas. So in some cases, the main healthcare facilities are hard to reach or are far from the villages or towns where a considerable amount of citizens are living. So we tried to find alternative ways to overcome medical deserts, and we tried to implement some digitalization initiatives, considering that we are experiencing this revolution in terms of digitalizations in many sectors of our lives, and the healthcare sector is one of them. In order to do so, our province, the province of Trento, decided to launch in 2016 a dedicated competence center that is called Trentino Salute 4.0. It's a competence center for digital health with the purpose of promoting, sustaining digitalization of the entire healthcare system in our province, and try to address the issues, to tackle the issues that we are facing, including medical desert. And it's an important experience also at the national level because it's a public-driven initiative. The actors of this system are the province of Trento, the autonomous province of Trento in its role of decision and policymaker, but we also have other two important partners in this center, the Local Healthcare Trust, APSS, and that is the service provider, and the Bruno Kessler Foundation, which is an internationally known research institute with high competencies in the field of digitalization and technology in particular. This Trentino Salute 4.0, this alliance and competence center, has promoted over the years many initiatives. And the main one is a digital platform that is called TREC. The TREC or TRECI is an acronym that stands for Cartella Clinica del Cittadino, meaning Citizen's Clinical Record. It is, in very practical terms, like a sort of digital environment where each citizen, regardless the place where he or she is living, could have equal access to the healthcare services. It is composed by a web portal, so it can be accessible via a laptop or a PC, but it can also be accessed through a mobile app. And this is the numbers are updated up to date. We reached this month 100,000 mobile users, and we have a total of 2,400,000 users. It means that almost the 50% of the entire population in our province is connected through this platform to the healthcare system, which is a percentage that is very high, is the highest one at national level. How the system looks like, well, we used to present it using this picture that you can see. TREC, it's like an ecosystem of services where each citizen can find different layer or different pillars of services that can be accessed regardless the place where the citizen is living. And we have three main pillars here in this digital environment. The first pillar is related to the online services, so the citizen can have access to the healthcare data, but can also have the possibility of having televisits and telemedicine services. And he or she can also manage their bookings with the healthcare staff or manage the payments to the healthcare system. Then we have a second pillar of services that are specifically targeting the citizens' empowerment. So the citizen can have here, again, support for the self-care and for recording personal data related to health. And we have a third pillar that is related to the mobile apps that can be used by the patients for supporting healthcare services. And I will make a focus later on this. It is important to underline that that we conceived this system like an environmental platform, like a digital alternative to the physical desert that in some cases the citizen might experience. And it is designed, as you can see from the picture, to cover ideally all the needs of different patients in different stages of their life, in different stages of their disease. And one of the core tools that we are using and promoting to overcome medical desert is the idea of the apps and digital services specifically designed for a specific target of patients. In particular, we developed this set of apps that can be prescribed by the medical doctor as part of the routine practice, and that can enable both the healthcare professionals and the patients to get in contact, to deliver healthcare services even remotely. So without the need for the patient of traveling across the province and to reach maybe an hospital that is far from home. The system is designed with two main components, a number of mobile apps that incorporate recommendations for the patients, but also they are enabling the possibility of accessing to telemedicine services. And we have different apps according to the different disease that the patient or the citizen is suffering. And we have also a medical dashboard for the healthcare professionals that can use and prescribe these apps to monitor the patient remotely or to intervene remotely when this is possible, of course. But the important issue here to underline is that this system is designed in such a way that the medical doctor and the healthcare staff, they have the possibility of prescribing these mobile apps as part of their routine tasks. And this means that this digital environment is actually an extension of the hospital and the physical environments where the healthcare professionals operate. We tried to design this system having in mind two main principles. The first one is the principle of a personalized and patient-centric or patient-centered approach. Each app, as I was mentioning, can be prescribed by the medical doctor as part of their routine practice. But this is not all. The medical doctor can also personalize the app in such a way that specific features are activated for specific patients because they need it. And vice versa, there is also the possibility for the patient, for the citizen, to personalize the app by him or herself. In this way, we can adapt, we can tailor the digital tool for the specific needs of the medical doctor and for the specific needs of the patient at the same time. And the app is also supported by an artificial intelligence coach that we are calling a virtual coach that can operate in agreement with the medical doctor. So the medical doctor can assign to the virtual coach specific tasks that the virtual coach can deliver to the patient. Like, for instance, reminding the patients for the treatment that he or she has to do, or administering periodical questionnaires on behalf of the medical doctor, so to collect additional information, or to monitor the adherence of the patient, him or herself. The second principle that we try to embed into this digital environment was the principle of the stepped care approach. As we said at the beginning, we are experiencing quite a critical situation in terms of shortage, for instance, or of healthcare professionals. So it is very important to make the public health system more sustainable. And the technologies can play a role on that. And what we designed here in this digital ecosystem is an approach where the low complexity cases can be managed by technology, so by the virtual coach. The lowest the complexity, the more likely is that we can assign to the technology specific tasks or specific interventions, so that we save time for the healthcare professionals, but we also save time for the patient, and they are not in the position of traveling across the province to reach the hospital or to receive a service. The higher the complexity, the more likely the medical doctor is to intervene. So by balancing the actions of technology on one side and medical doctors on the other, we are trying to, on one side, enlarge the actions that we can do as a public health actors. So we are mitigating the medical desert. And on the other side, we are trying to promote sustainability of the system by balancing the work that can be done by the technologies and the work that has to be done by a human component, that is our healthcare professionals. So just to conclude, it's the take-home message, the summary of the model that we are trying to promote to overcome medical desert. It can be summarized in this picture. This is the plan that we are trying to implement through this technology. We know that there is a significant amount of actions, tasks, services that can be assigned to technology, either artificial intelligence algorithms or virtual coaches embedded into app. And we know that we might have an additional layer here, that is the telemedicine, that is the possibility of healthcare staff to get in contact with the patients remotely via, for instance, televisits or remote distance assistance. And in our model, the very last layer is the layer where the patient is required to go to the hospital and the medical doctor has to be there for a face-to-face visit or a face-to-face intervention. This pyramid is somehow the system that we are trying to put in place here to try to tackle the medical desert by optimizing the use of technology on one side and optimizing the actions of our healthcare professionals only when it's needed. Thank you very much. I think I keep my 15 minutes. If you have questions, I will be happy to take them at the end in the questions and answer session. Thank you.
Thanks a lot, Lorenzo, also to keep the time. Very interesting presentation. I would like also to add that the track practice was also identified in another Italian project as a best practice. And we are going to transfer this practice from the Trento province to other Italian regions. So just to also underline the value of this practice. Thanks a lot. And now we would like to give the floor to Guillaume Chevillard, that is researchers at IRDES. IRDES is a research institute in France. They are also partners in Noesis, let's say key partner. because they are in charge of analyzing and identify possible methodologies to measure the medical desertification. And in the next presentation, we are going to present the results of an analysis on some policy measures that were implemented in France and their effect on the medical desertification in France. So please, Guillaume, the floor is yours.
Thank you, Paolo. Good afternoon, everybody. I hope that you hear me well.
Very well, thank you.
On my screen. So thank you also to the organizer for the invitation. So I'm glad to present you two French policies to mitigate medical desert. The first one is about primary care teams, and the second one is about the limitation of nurses' installation in overserved areas. So I will start with some element about the French context. You have to know that in 2022, 30% of the population lives in a medical desert in terms of general practitioner. First, medical desert appears in rural areas, but now it concerns all kinds of places, such as suburban areas or metropolitan areas. And you can see on the map of France, the red areas are the medical desert. The medical desertification starts in the beginning of the millennium and will continue until 2030. And this phenomenon is more intense in rural fringes. Rural fringes or rural areas that are less attractive for both population and doctors. You have to keep in mind, because it's a part of the solution, that during the same time, there is an increase in France in the number of nurses, midwives, and physiotherapists. So what are the French answers to improve accessibility to general practitioners? So since 2005, three types of measures have been deployed by public authorities. The first one is to increase the global number of doctors. So for example, it was to increase the number of medical students or also to recruit foreign trained or foreign born doctors. The second type of measure is to attract and retain general practitioners in medical deserts through financial incentive, but also through the improvement of working conditions. We will see this example through primary care teams later. The third type of measure is to increase the GP's availability and to reorganize the primary care delivery. So some example could be the creation of physician assistants, the development of skill mix with nurses to promote more the coordinate exercise. It could also be e-health, etc., etc. There is still a big debate in France, political debate about medical desert, and we have two more measures that are discussing. The first one is to limit installation of GPs in overserved areas, such as it exists for nurses, physiotherapists, and midwives. The other point of the debate is to add a fourth year of medical internship, primarily in medical desert for GPs. So I will present you the first case, the first example about primary care team. So with my colleague Julien Mousquet, we were wondering if primary care team are a way to attract and retain doctors in medical desert. You could find the entire this entire work on social science and medicine. So some definition background. The primary care teams groups together general practitioners and other paramedics that are self-employed. Public authorities financially support PCTs for both their construction and operating costs. So it leads, as you can see on the figure, to an exponential increase of primary care teams. So there were 20 PCTs in 2008, and now we have more than 2,000 primary care team in France, as you can see on the map. These primary care teams are primarily in medical desert that we define such as the rural fringes and suburban areas. So the objective of our study was to see the impact of primary care team on GP's density evolution. To do that, we compare the evolution of GP's densities in similar type of areas that have PCTs and similar ones that don't have the primary care team. And I will show you the results in suburban areas and rural fringes. So the result in suburban areas, this graphic shows you the evolution of GP's densities in suburban areas with and without primary care teams between 2004 and 2017. So as you can see, we have the red curve is the areas with PCTs and the blue one are similar areas that don't have PCTs. As you can see, before the development of PCTs, so approximately around 2010, we have the same tendency of evolution of density in both type of areas. And after 2010, we have an improvement of the densities of GPs in suburban areas that have primary care team, when during the same time, there is still a decrease of the densities of GPs in other areas. At the end of the period, we estimate that the impact of primary care team are of 3.7 GPs for 100,000 people in favor of areas that have primary care teams. We analyze the same thing only with the densities of young GPs, just to analyze the attractivity for young GPs. And we see the same result, but with a more intense impact of primary care teams in suburban areas. So that's the same concept here, just to show you that it's very effective for young GPs. Now I will present you the same thing in other type of areas that are the rural fringes. So the rural fringes appear in the card, in the map on greens, your rural areas not attractive for people and doctors. So this graphic also shows the evolution of GP's densities in both control and treated areas. So we start higher here in terms of density, but as you can see, before 2010, we have the same tendency between areas that have PCTs in red and other ones similar that don't have PCTs. And after 2010, we have a less worst decrease of the densities of GPs in areas with a primary care team. In the end of the period, we estimate the impact around 3 GPs for 100,000 people in favor of areas with primary care team. We also do the same thing for young GPs, and what is interesting here is that even if these rural fringes that are not very attractive, we have an impact positive and significant of the presence of primary care team, as you can see on this graph. So to conclude about the primary care team, what you have to keep in mind is that globally, we show that areas with PCTs have a better evolution of GPs and young GPs densities than similar areas without PCTs. The impact of PCTs is mainly explained by the attractivity for young GPs, and this impact is not the same according to the type of territory, as we have seen with suburban areas and rural fringes. Due to the global decrease of GPs in France, and especially in rural fringes, PCTs are not sufficient to mitigate the medical desertification. But other works show that GPs in primary care team see more patients than other ones. So these two results show that primary care team is a way to both attract young GPs in medical desert and to produce more care here. So other complementary answers than PCTs are required in France with short and long-term vision that could be to improve more coordination and cooperation, skill mix with paramedics, to rethink the recruitment of students, etc., etc. I have 4 minutes to present you the second example about a second policy consisting in limiting nurses' installation in overserved areas. So with my colleague Fanny Duchesne and Julien Mousquez, we were wondering if it's a way to improve geographical distribution of self-employed nurses, and you can find this entire work on the Revue d'économie régionale et urbaine, but it's in French. So some context elements, the number of self-employed nurses increased in France since 2006. There are still geographical disparities, but they are reducing through time. Since 2012, public authorities defined a limitation of installation for nurses in overserved areas that you can see in blue on the map, and a financial incentive to install in underserved areas that you can see in red. So we were wondering if this type of regulation is efficient to reduce geographical inequalities. To do so, we compare nurses' densities evolution between overserved areas and similar ones that we pick in the intermediate areas with matching methods. And we do the same thing for underserved areas compared to similar ones in the intermediate areas. So I will present you the results. This result presents you the evolution of the global densities of self-employed nurses in underserved and overserved and intermediate areas between 2006 and 2016 in France. So as you can see, the red curve is the evolution in overserved areas. So we see that it increased until 2012, and then it slowly decreased when during the same time, the densities of nurses is still increasing in underserved areas and intermediate areas, but it is on the same with the same trend of progression. We do like previously the same thing for young nurses to see if it's attractive for them, and it's more interesting here. So we focus on the young nurses and the evolution of their densities, and as you can see, we have an increase of the densities in overserved areas, but we have a higher decrease of the densities in such areas since 2012, when during the same time, there is a quite similar evolution for the densities of young nurses in underserved and intermediate areas. What is interesting here is that we have a convergence in terms of installation of young nurses between these three types of territories. To conclude with this politic of limiting nurses installation, we could say with our studies that it's a good answer, but it's in a context of an increasing number of nurses. So we show that it's very efficient to limit the increase of nurses density in overserved areas, and especially for young nurses, but it does not benefit to underserved area much more than to intermediate areas, because we have the same trend of progression. And thank you for your attention.
Thank you, Guillaume. A very interesting presentation, and the results from this analysis. Interesting to see how some measures can work under certain circumstances and the other not. Okay, this is also very, very interesting, and for sure, well, more analysis are needed, of course, for these policies. Okay, so now it's time for the attendees for your questions. So please feel free to ask questions to the panelists using the Q&A box. I'm not seeing anyone in the meanwhile. Maybe I have a couple of questions. So if I can, let's say, break the ice, I have one question to Lorenzo regarding their experience in Trento with the digital environment. And I would like to ask you about how the health professionals that are engaged in your system, how do they react to this digital ecosystem? If there are any reluctance to change. We all know that one of the problems is the reluctance to change when we talk about digital solution. And on the other hand, if you had also positive experience regarding maybe an increase of motivation or more engagement. So what was your experience with involvement of the health professionals?
Thank you, Paul. Well, you are touching quite an important issue in the sense that whatever change we are trying to implement is in any way a change that is targeting the healthcare professionals, so their involvement is absolutely key. Well, in general, the involvement was very, very good because of the overall structure that is the organizational structure that is behind the project. The fact that Trentino Salute is merging together the policy with the province of Trento, but also the healthcare trust as a main stakeholder of this initiative, was somehow facilitating the involvement of the healthcare professionals. I have to say that also in promoting this strategy, we try to adopt a co-design approach, meaning that the overall project, but also the specific apps and platform were co-designed by involving patients on one side, so even the patients, the associations, the NGOs from our communities, but also selected groups of healthcare professionals who were involved to co-design together with the IT professionals the different tools and platforms. So this was somehow an approach that we used to facilitate the adoption of the system, and in general it worked well. I have to say that in any way there was a certain level of reluctance from specific colleagues, but it's part of the game when you are trying to innovate a system. And but I have to say that the COVID pandemic was a random and non-predicted factor who, I have to say, facilitated very much the adoption of digital solutions, because even the most reluctant colleagues, they had, unfortunately, on one side, they had the chance to appreciate and to assess the efficacy of the specific tools, like, for instance, the telemedicine tools, particularly during the COVID pandemic. So the pandemic has this side effect to create a very critical environment where we had all the chance to implement, and it was somehow a must, implement telemedicine tools. And somehow we had the chance to involve also specific colleagues that were maybe not so familiar with the technology. So in general, I have to say that the involvement was very good across all the levels.
Thank you a lot, Lorenzo. And sorry, another related question regarding, let's say, the aging, both of the population and also of the health workforce, of course. So it's a factor that actually can be considered a barrier or not.
Well, it's a complex question. It's the overall answer is difficult to be found, but in some cases, I have to say that the most experienced health professionals were, in the majority of cases, less familiar with the technology, of course, but they were able to compensate with a lot of expertise in terms of, managing the relation with the patient, because sometimes managing a patient remotely is more difficult than managing a patient face-to-face. So even if they were not or less familiar with technology compared to the young colleagues, they were more expert in terms of managing the relation with the patient. So we had very good surprises from this perspective. With regard to the patients as well, in general, it's true, is the digital divide phenomenon. No? If you use a technology by design, by default, you are introducing somehow a barrier particularly for the elderly. But I have to say that also in this case, it was interesting to see the role of the caregivers. They were, even if the grandfather was not able to use the technology as a patient, in the majority of cases, we have seen the contribution of the caregivers, the child or the members of the family, helping the patient in using technology. And this was a side effect that was very positive, because somehow through technologies, we also were able to motivate the members of the family to collaborate with the patient in supporting the self-care, also with the mediation of the technological tools. So maybe the patient was not able to use it, but another member of the family was able to use it. So this was somehow a way to reinforce the relation within the family and to increase the self-support and the support within the family, among the family members. So this is also an effect that we have to consider when we are introducing technology to monitor or to manage patients remotely.
Thanks a lot, Lorenzo. Good to know that digital tools can also be considered as a solution to mitigate the problems within the families, family policies. Thank you a lot. And I also have at least one question to Liam regarding one of the solutions that he presented. I'm referring to the primary care center, so the Maison de Santé in French, in which you show that under certain circumstances, so especially if I got it well in the suburb areas, and especially within young doctors, can be considered as a solution to improve the retention, to improve the attractiveness of young medical doctors, and so to mitigate the medical desert. But have you analyzed also the reason why for the young medical doctors, these primary care centers can be considered attractive. I'm asking also because, for example, in Italy, we are going to implement also our Maison de Santé, comunità, case della salute, or yes, case della salute in Italy. So I'm also curious to listen to your recommendation, let's say, from your perspective.
Thank you, Paolo. Yeah, it's a good question. We observe why it's we observe that it's attractive, but we don't explain why it is attractive for young GPs. But what we have before we made these studies, we have some surveys that shows that the determinant of installation of young GPs are gathered in a true find answer in primary care team. For example, there are three main determinants that are important for young GPs when they settle somewhere. The first one is to be near the place they have grown. The second one is to have working conditions that are efficient for them. So the primary care team answer to that. They don't want anymore to exercise alone, the young GPs in France. And the third one is, and maybe that explains the difference of efficacy of primary care teams through the territories. The third determinant is to find service, amenities, etc. in the territory. So it could explain why we have such difference between suburban areas that are not far from the cities, where you have more school, employment for the spouse, etc., etc., and rural fringes where such amenities are more far from this area. So it could be an explanation of this. But also we have another reflection in France, but it's not a short-term answer, but we thought that it could be relevant to do such as in other countries, to diversify the profile of medical students according to the type of territories, rural, urban, etc. Because there will be naturally there will be more probabilities that they settle in some areas where they have grown, study, etc. And it could be more relevant than to absolutely try to give in rural areas some equipment or amenities that are not present. So it's a long-term answer, but it could be another way to answer to medical desert in France with this long-term vision.
Thanks a lot, Guillaume. And Marta is telling me that there is an hand raised from one of the participants. Is it possible to give the floor?
It's Gaetan Laforge. Yes, I can give the floor to Gaetan, sure.
Okay, yeah, please, Gaetan.
Hello, can you hear me?
Yeah, yeah.
Okay.
Hello.
Hello, Paolo. Thanks a lot. A great webinar, and a few remarks, and then one or two questions, like on the definition of medical deserts. Like there was quite a lot of differences between the definition that Muna first presented and the definition that the narrower definition that Guillaume presented for the French situation. Like in Muna's presentation, it was general access to care, including financial, not only geographic distance, but also waiting times and financial access. While in Guillaume's presentation, it was much more focused on access to general practitioner. It's all fine. Like we can use different definition. I always say that the definition of medical desert is elastic and may be adapted to different circumstances. But it's always important to say which definition is being used. Because on your presentation, Guillaume, like you mentioned at the beginning of your presentation that 30% of the population is living in medical deserts. But if you look at the different definitions that are used in France, like you can go from about 5% to about 50% of the population, depending on the definition that is used. So it's quite important to define like whether it's only access, the availability of GP, whether it's availability of GP adjusted for need. And so there are different ways of measuring this that will come to different results. Now, in terms of the policy action, I think this webinar is focused on what are the two most promising policy actions to deal with medical deserts. First, using other people than GPs to provide services. It can be nurses. There was a fair bit of focus on nurses. It can also be pharmacists or other people who may be more spread out in the territory. And the second solution is what Lorenzo presented. Just a few comments, mainly on the first policy action, on the role of other providers. Well, first, very interesting to see that in France, like over the past 10 years, there have been regulation to limit the location of practice of nurses that are working as a self-employed, and but then the obvious issue is if you can do it for nurses, why can't you do it for GPs also? And then there are obviously some big resistance to this. But then the question for you, sorry for this long intervention, Paolo, probably more for you, Paolo, but also possibly for Lorenzo. Your country created a new role, which is for nurses, which in English is translated as family and community nurses, and that's exactly where that role was created at the beginning of the pandemic. What is happening? Is the role spreading? My understanding was that it would play more or less the role, or it would take on some of the tasks that the GPs are usually providing, either in underserved areas or in other areas. So what is happening with this? Thank you very much.
Well, I can bring if I can, Paolo,
please,
the experience in the province of Trento. I mean, you're right, and thank you for pointing out this issue, because it's somehow a change that is about to occur, and in many cases is already there in our organizational asset in the public health sector. Where actually in the province of Trento we already piloted, and we managed to publish also a paper on this. We are piloting actually, we piloted a feasibility study to understand what is the role that can be flexible by definition of this specific nurse in the context of managing patients with chronic diseases in particular. And well, I can share later on with you, but also with other colleagues, maybe some preliminary results of the piloting that we are doing. We just closed a pilot project in the last months, and at the moment we are running another feasibility study in another area of our province, exactly to explore the degree to which this nurse can be adaptable to different contexts, because in the overall model, the role of the nurse, of the family nurse, can in some cases replace specific actions of the general practitioners. In other cases, she or he can act as a link between the medicine on the territory and the medicine of the hospital, so the GPs and the specialists. So it's really a gray area, at least in our province. So we are trying to understand through these piloting projects when and how this new actor can be placed within the public health system, and where this nurse can be the most effective in terms of sustainability also of the system and the action. So I can share with you some preliminary results and maybe share the results also with other colleagues and the results that we will have in the coming month. Sorry, Paolo, I just
no, thanks. No. thank you for your answer and feedback. And may I ask Guillaume to react to the comment by Gaëtan regarding, well, the many possible definition of medical deserts and the ones that you are using in France.
Yes, thank you, Paolo. Thank you, Gaëtan, for the question. Of course, I totally agree about when you talk about elasticity definition of medical desert, because in France we have an approach profession by profession, what we call in silo, and I think what present Mouna is a global and large definition of the lake of access, etc., with its different components. So, of course, in France we don't have a consensus about this definition. We have this definition is used to define areas where we deploy incentive to attract and retain GPs, but we don't have a real reflection about accessibility to several professionals. That's one of the stake of what we do in the WIPI4 to develop a composite index to several professionals to bring more element to that. And the second interesting point, but maybe Gaëtan knows the answer, is always the question of why we can't limit in France the installation for doctors. Of course, it's in debate since 5 or 6 years, and doctors are very influent in the parliament. So for now, it's not a debate, but more pragmatically, I have doubt on this type of measure, not globally, but just in this context of decrease of the number of GPs, because this decrease affects all kind of territories, even the over or well-served areas. So it can be really relevant until 2030, but after, as we can see for the example for nurses, after when the number of doctors will increase more, it could be a very relevant tool to better disperse them on the territory. So thank you, Gaëtan, for this remark.
And thanks, Guillermo, for your feedback. And I think that, well, the time is over, basically. So would like just to thank all of you, all the panelists and all the attendees, and just to inform you that, of course, the OASIS partners will continue their work and their analysis in the next 14 months, and we'll be very happy and glad in the next webinar to show you more results from our analysis, from our experiences, especially for the pilot studies that are going to start in the 7 countries that I mentioned before. So thank you all, and enjoy you nice evening to all of you. So let's keep in touch and see you next time.